Dr. Paul Gomez from the Department of Ophthalmology, and today we'll talk all about uveitis, one of the disease entities that you will encounter in the clinics. Um, when you encounter patients in the clinics who have red eye, this has one of the differentials that you have to keep in mind. Hindi lahat ng nagre-red eye, sore eyes, dry eye strain, irritation lang. One of the differentials that you have to consider, especially if you look at the history, the profile of the patients, one of the considerations is red eye from uveitis. Mm. So, uveitis is the inflammation of the uveal tract.
The
The uveal
recording
tract,
has stopped.
oh, what happened? Tuloy lang. So, uveitis is the inflammation of the uveal tract, and the uveal tract is composed of the iris, the ciliary body, and the choroid. The iris is the colored part of the eye that controls the amount of light that enters the pupil. The ciliary body is the part of the eye that produces aqueous humor and contains the muscles that focus the lens or accommodation, while the choroid is a layer of blood vessels and connective tissue between the retina and the sclera, and its primary function is to nourish the outer layers of the retina. Uveitis is simply an inflammation of one or more of these structures. But inflammation may spill over to adjacent structures. So if it affects the sclera, you can term it as scleritis. If it affects the vitreous, that's vitritis. If it goes in front of the eye and affects the cornea, that's keratouveitis. And if it affects the retina, that's retinitis. Usually, patients with uveitis affects it, are around 20 to 60 years old, but sometimes it can occur at any age. So, of course, when you see a patient, you have to get the history, you have to ask the chief complaint. And the usual chief complaints of these patients include, but not limited to, blurred vision, eye redness, photophobia, o naiilawan, pag naiilawan, masakit sa mata, eye pain, and baka may lumulutang silang nakikita, what you call floaters. And you also have to ask for the onset of symptoms. You can actually classify uveitis depending on the onset of symptoms. That would either be acute, recurrent, or chronic. If it's acute, there's a sudden onset of symptoms and may have a limited duration. If it's recurrent, there may be repeated attacks of inflammation, separated by periods of inactivity without treatment of at least 3 months. But if there's persistent inflammation with relapse within 3 months of discontinuing treatment, that is chronic uveitis. You also have to look at the laterality. Kanang mata lang ba? Kaliwang mata lang ba? Or baka both eyes yung affected for the patient. The pattern and timing of symptoms must also be looked at. So you have to ask, kailan to nangyayari? Do the symptoms become more severe at certain times of the day or baka related to any of their activities? And also, you have to look at the other pertinent histories of the patient. So if there is for the ocular history, did the patient have any prior surgeries sa mata, prior eye trauma, spectacle use? Nakapagpatingin na ba siya sa ibang doktor sa mata? Meron ba siyang mga pinapatak na gamot na para sa mata? You have to look into the ocular history. You also have to look at the past medical history. So yung mga usual tinatanong, dapat tanungin pa rin. Meron po ba kayong high blood, diabetes, asthma, heart disease? Uh, Pero yung mga pertinent usually sa uveitis, the patient have arthritis, sumasakit ba yung mga kasukasuan, yung likod, yung bewang, nagkaroon ba siya ng sakit sa baga dati, naggamot ba siya na matagalan for TB, mga 6 months. And you also have to ask kung nagsisteroids ba siya for whatever reason. Family medical history is also important for possible hereditary diseases. And of course, social history is also important, especially merong mga uveitis na related sa sexual history ng pasyente. After you got your thorough patient history, you go to the ocular examination. Super pertinent pa rin yung mga tinuturo namin sa inyo, yung 5-point exam, visual acuity, gross examination, EOM, stonometry, fundoscopy, and first and foremost of these is syempre yung visual acuity. A good visual acuity may signify that the patient may have a relatively more benign disease, but a worse visual acuity may suggest a worse uveitic disease. But this may not always be the case. So, kailangan pa rin alam nyo yung step-by-step process kung paano kunin yung visual acuity. Then afterwards, you do your gross examination. When you do gross examination for these patients, there's some kind of eye redness. The pattern of eye redness may point to what eye condition the patient may have. In particular, kailangan mo ma-delineate kung ano yung conjunctival redness injection or yung ciliary injection. Dun sa top left corner ng picture, you can see that there's conjunctival injection. It appears more widespread and may spare the perilimbal area. It is often associated with sore eyes, conjunctivitis, dry eye, or eye irritation. However, kung more ciliary yung appearance no eye redness niya, may ciliary injection, there might be pronounced redness around the eye, around the limbus, and it may point to a uveitic disorder. But of course, kung gross examination lang, technically, hindi ka dapat maging kontento. You must try to examine the patient in a magnified view using a slit lamp. So if you do pursue ophthalmology, you will have to perform slit lamp examination for these patients where you can see eye structures up close and make a better distinction between these findings. So kita dito sa mga pictures na to yung difference ng ciliary injection and yung conjunctival injection. And aside from eye redness, kapag nag-slit lamp examination ka, it may reveal other findings in uveitic eyes. So may see inflammatory cells floating in the anterior chamber. The cornea may also be hazy from inflammation, which you may coin as a flare. Um, hindi na sakop ng med school, but may mga grading for cells and flares. And these inflammatory cells then may also clump under the cornea or on the endothelium and may form keratotic precipitates. Sa slit lamp then, you can also see some possible pupillary abnormalities in uveitic eyes. So if there's adherence of iris tissue to the lens, we can call that as posterior synechia. Nakikita nyo dito sa mga pictures na to. This may impede outflow of aqueous and inadvertently increase intraocular pressure, leading to glaucoma. And dahil nagkakaroon ng synechial adherence din yung iris to the lens, yung lens mismo pwedeng maging cataract or cataractogenic yung gitong problema. And sa slit lamp then, you can see that in advanced cases, the inflammation can spill over to the cornea and form a band keratopathy. So EOMs, when you go to the EOM examination, it may be affected in certain uveitic entities. If there is pain during eye movement, certain diseases may be considered, as we will discuss later. So as I've mentioned, the uveitis may or may not affect the eye pressure. So formation of adherent tissue around the pupil, as I've mentioned, will be called as posterior synechia. But certain conditions may also close the drainage canal of the eye, as seen as peripheral anterior synechia, leading to secondary glaucoma. Ay, tama. So for you guys, we also teach direct ophthalmoscopy to see a magnified view of the retina, the optic nerve. However, for using direct ophthalmoscopy, you can't really see the other details of the retina. And if you do pursue ophthalmology, of course, you will be taught how to examine the retina using other methods, possibly with a 90D lens or indirect ophthalmoscopy. So with these methods, you can appreciate the fundus at a larger scale. So as seen in these pictures, retina findings for uveitic eyes may include the following. For the top left picture, the vitreous may be hazy because of inflammatory cells floating in the vitreous cavity. The top left photo shows clo- uh, balls, white balls, termed as snowballs, that are inflammatory material deposited in the retina. The top right picture shows a brush fire-like appearance or a bleeding in the retina, termed as vasculitis. And the bottom photo shows an exudative type of retinal detachment that may be present in certain uveitic diseases. And if left untreated, all of these lesions in the retina may eventually form retinal scar. So earlier, I've mentioned that we can classify uveitis according to the onset of symptoms, acute, chronic, and recurrent. But we proceed now to another way to classify uveitis, and that is based on anatomy or where the inflammation is located. If the iris and ciliary body are affected, that's coined as anterior uveitis. If the pars plana and the anterior vitreous is inflamed, that is intermediate uveitis. We can call it as a posterior uveitis if the retina and the choroid are affected. And if everything is affected, the entire uveal tract is affected, that is called panuveitis. So another classification is based on pathology. I've mentioned earlier yung mga creatic precipitates that may form behind the cornea as inflammatory cells deposit behind the cornea. So the appearance of creatic precipitates may help in the delineation of this disease. So if the key creatic precipitates or KPs have a finer, smaller, whitish appearance, that is non-granulomatous type of uveitis. Localized in the anterior segments and may be acute in nature, that may, and these uveitis may have a present. It may signify that the entire uveal tract is affected and may be chronic in nature and may be secondary to sarcoidosis, VKH or Vaught-Koyanagi-Harada syndrome, or possibly tuberculous uveitis. We can also classify uveitis based on its etiology. So it should be noted that uveitis usually happens as quote unquote the eye sympathizes with another body part. So when there's infection or inflammation elsewhere, the eye may become inflamed as well. So that's why we have to look at the possible causes of uveitis. If the patient has tuberculosis, syphilis, the uveitis may be bacterial in nature. If the patient is infected with herpes, simplex, zoster, or possibly immunocompromised and may have a CMV infection, the uveitis is viral in nature. If the patient has infected with fungal elements, histoplasmosis, coccidiomycosis, that's fungal, and also parasitic infections such as toxoplasmosis or toxocariasis. An immunologic cause of uveitis may be considered if the patient has lens-induced uveitis or sympathetic ophthalmia, wherein one eye has been traumatized and the other eye technically sympathizes with the injured eye. Uveitis may also be systemic in nature, such as in writer's disease, sarcoidosis, arthritis, or VKH or Vogt-Koyanagi-Harada syndrome. And it also may be neoplastic in nature, as patients may have concomitant sarcoma and lymphoma. So now we proceed with the diagnostic examinations. I just emphasized that the eye becomes inflamed because of inflammation elsewhere, and we can classify uveitis based on etiology. As such, it is prudent that we should order several tests to determine the culprit. If it's tuberculous in nature, or the patient may have syphilis, if that's your primary suspicion, maybe you can order chest x-ray, PPD, or PR. If you're looking at viral infection, maybe you can order PCR. If you are looking at concomitant parasitic infection, so with toxoplasmosis or toxocariasis, maybe you can order IgG and IgM for these patients. If you're looking at rheumatoid arthritis or VKH, possible tests that you may order include ANA, CSF, pleocytosis. And additionally, you should order baseline CBC, ESR, CRP, and metabolic panel to assess for general organ function. Several ancillary eye tests may also be ordered for uveitis: retina photographs, FA or fluorescent angiography, OCT, or ocular ultrasound. Fundus photographs or retina photographs may reveal may help the clinician look at the possible etiology, especially based on the appearance. As seen in these examples, the top photo shows an atrophic scar from toxoplasmosis. Middle photo shows a frosted branch angeitis or a retinal vessel sheathing seen in CMV or cytomegalovirus infection. The bottom photo shows a macular star and optic disc edema as seen in patients with neuroretinitis. And if you do serial retina photographs, you can see improvement or eventual worsening of the eye condition. And based on that, it may help the ophthalmologist to determine if the patient can be tapered off the treatments, or if there is a warranted intensifying of the treatment as necessary. And as an adjunct to retinal photographs, you have to ask for fluorescein angiography. So in this test, a fluorescent dye is injected intravenously to highlight or light up the blood flow in the retina, which may present as staining, seen in the top photo. The leaky structures are all seen, can be appreciated in the middle and the bottom pictures, or the FA may also show some obstruction. And another ancillary test is OCT or optical coherence tomography. It provides an optical cross-section of the eye. So in these pictures, you can see a normal retina, and the corresponding OCT will show a smooth, curvaceous contour devoid of any edema, intraretinal deposits, nor detachments in the macular area of the eye. However, in uveitic eyes, the OCT may reveal several problems. So the top left photo shows an example of an exudative retinal detachment. The top right photo shows a retinal pigment epithelium detachment. The bottom left photo shows an example of an atrophic scar. And the bottom right photo shows the presence of intraretinal cysts. Different conditions, different prognoses, different treatment needed. So these tests that I've shown you can only be done if there's a good and clear view of the fundus or the retina. There are instances that there is obstruction of the view, and we need something else, another test to appreciate the posterior part of the eye. And that is where an ocular ultrasound or a B scan can be handy. B scan because it's called a brightness type of ultrasound. So, for example, in these top photos, there is a large hyphema in the anterior chamber. The lens, the cataract, may be really thick or brunescent, and there might be some form of vitreous hemorrhage or haze that may impede the view of the retina. And in these cases, an ocular ultrasound can be ordered. In a normal eye, an ocular ultrasound will show something like this. You can see the cornea, the anterior chamber, the lens, and its corresponding anterior and posterior capsules. The vitreous cavity is clear without any opacities, and you can appreciate the retina attached to the sclera. And you can also see at the very far posterior segment of it is the shadow of the optic disc. In certain UV conditions, you can, when you order an ultrasound, you can appreciate possibly vitreous hemorrhage, as seen in the top photo, or the bottom photo shows a possible detached retina. Okay, sorry. So now that we've talked about diagnostics, we should also give an overview of the therapeutic goals for uveitic eyes. These are the four goals that we aim to address and achieve in the fight against uveitis. First is the control of inflammation. So we can control inflammation for these patients with the use of topical drops, corticosteroids, steroid drops, NSAIDs, and there might be immunomodulatory oral drugs that we can also give for the patient. But there are certain conditions that you may need to address infection first before starting any steroid treatment. You must also address the vision threatening complications of uveitis. Usually for these patients, as I've mentioned earlier, the lens may become cataractous eventually. So the patient may need to undergo some form of lens extraction. But the usual paradigm that we uh, follow is that before any lens extraction, there must be a quiescent stage of inflammation. There's no inflammation. The inflammation is controlled for at least 3 months before asking the patient to undergo any form of lens extraction. If there is a secondary form of glaucoma, the pressure becomes high and higher. The optic nerve becomes damaged because of this high pressure. You have to give the patient possibly anti-glaucoma drugs, topical drops. And if it cannot be controlled with drops alone, the patient may need to undergo some form of glaucoma surgery. And I also have to emphasize that uh, prolonged steroid use can also uh, have a effect that causes a high intraocular pressure. So the control of inflammation must be balanced out with the control of IOP. If there is a retinal problem, as I've seen earlier, uh, ex- as we've shown earlier, if there is inflammation of the retina, if there is bleeding, patient may need to be injected with anti-inflammatory drugs. If there is an behind the retina, or if there's retinal detachment, the patient may need to also undergo some form of retina surgery. You must also look at the pain of the patient because brought about by uveitis. So you have to relieve these symptoms of these patients. So usually we can give cycloplegic agents for these cases, atropine, and cycloplegic agents may dilate the pupil for prevention of iris adhesion to the lens and may relieve pain by immobilizing the iris. Systemic pain medications may also be prescribed if needed. And as I highlighted earlier, the underlying cause must also be addressed. Proper identification of the etiology will lead to proper prescription of needed drugs in the form of antibiotics, antivirals, antifungals, possibly immunosuppressive agents, or biologic drugs. So that ends the first lecture for this morning. Do you have any questions? Does anyone in the chat box or anyone in the audience have any questions? Puro attendance lang. May questions ba? Wala. Isip. Okay. Anyway, may second lecture pa. Okay, since there are no questions, we can proceed to the second part of today's lecture, and that is mm, episcleritis and scleritis. So these two disease entities that you may or may not come across in the clinics. And it's also one of the differentials if you see a patient with some form of eye redness. So we go to the first one, that is episcleritis. That is inflammation of the tissue between the conjunctiva and the sclera. It is usually benign in nature, usually self-limiting, that lasts usually within just 1 to 3 weeks. It has a female preponderance and is usually seen in patients who are already in the fourth to fifth decade of their lives. It is usually unilateral, may resolve spontaneously, and the patient may complain of some mild discomfort and is idiopathic in nature as systemic associations are not common. So as we can see in this picture, the episcleral vessels are inflamed. And if you instill a topical vasoconstrictor, such as phenylephrine, it can blanch. This top photo shows the same eye after 3 minutes of 5% phenylephrine installation, showing significant vessel blanching. Episcleritis can be classified as either simple, diffuse, or nodular type. Simple diffuse uveitis, episcleritis, is usually more common. It is self-limiting, lasts just 1 to 2 weeks, often without discomfort, and you can offer the patient to instill some topical NSAIDs or possibly weaker steroid drops. If there is a nodular appearance or the vessels are inflamed and there is a nodular tissue associated with it, that's nodular episcleritis. It may take longer to resolve, 4 to 6 weeks. A patient will also complain of possible discomfort. The patient may need to be given topical NSAIDs or possibly some oral steroids. So if episcleritis earlier is a benign disease, then it is scleritis that a doctor and a patient must be wary of. Scleritis is the severe inflammation of the sclera. It may be recurrent. There's female preponderance, and it usually happens when the patient is in the fourth to sixth decade of life. It is often bilateral. It is associated with immune disorders such as rheumatoid arthritis, SLE, spondyloarthropathies, and possibly giant cell arteritis. The patient may complain of a severe, boring ocular pain associated with tearing, blurred vision, and photophobia. And you can see in these pictures, hindi lang masyadong highlighted, but the vessels that are inflamed are not just in the episcleral area, they are more deeper in nature, in the sclera mismo. And even if you instill phenylephrine, a vasoconstrictor, it does not blanch. We can classify scleritis either as anterior scleritis or posterior scleritis. Anterior scleritis can further be classified as either diffuse. It may be confused with episcleritis, but the inflamed vessels will be seen in deeper scleral structures. Anterior scleritis may be nodular in appearance. The nodules may be immobile and tender to touch. Anterior scleritis may present as a necrotizing type of appearance. There is an avascular appearance, almost translucent sclera associated with rheumatoid arthritis. And if it becomes more severe, that may become scleromalacia. a more severe progressive thinning of the sclera that may lead to holes or perforations that allow uveal tissue to prolapse and is also associated with rheumatoid arthritis. The other classification of scleritis is the posterior type of scleritis. It is rarer, has a female preponderance, and is usually bilateral. Patients may complain of periocular pain, and kapag nagpa-EOM examination kayo, there's pain in eye movement. And also, the patient may also have a decreased vision. Associated findings are chemosis, possibly proptosis, and lid swelling. And if you look at the posterior part of the eye, the retina may present with non-specific findings that may be such as the following, but may not be limited to disc swelling, choroidal folds, serous retinal detachments, uveal effusions, or macular edema. As such, the physician must have a high clinical suspicion of posterior scleritis. Possible conditions that may cause this type of disease may include connective tissue diseases, as seen in arthritis, SLE, or IBD, inflammatory bowel disease, possibly infections from herpes, tuberculosis, syphilis, or fungal in nature, vasculitic diseases, as in Wegener's, possibly Behcet's, GCA, and other possible conditions that may lead to posterior scleritis include gout, chemical injury, psoriasis, and postoperative inflammation. So if you order a B scan, an ocular ultrasound, in this picture, you can see a normal B scan will show just a thin slab of retina and scleral tissue. But as seen in this photo, a B scan, an ocular ultrasound may show B scan in patients with posterior scleritis may show a thick sclera or scleral thickening. I got this from the another one journal. So this is posterior scleritis in an immunocompromised patient. The initial photos, the retina photographs shows optic disc swelling, and the initial ultrasound shows posterior scleral thickening and a retrobulbar edema. However, after initiation of treatments, antiretroviral drugs, and possibly some steroids, these findings improve over time and eventually resolve. And similarly, the therapeutic goals, we have to go back to the four pillars of therapeutic goals in uveitis. But what's a little bit more peculiar in this is that you will need systemic anti-inflammatory therapy in these patients, as topical steroids most likely will be inadequate. And if you look at the underlying cause, you have to look if it is infectious in nature. If it is infectious in nature, you have to start antimicrobial therapy first prior to initiating any anti-inflammatory drugs. But if it is non-infectious, we may go straight to immunomodulatory therapy, and NSAIDs may also be used. And lastly, individualized treatment is needed based on severity and association with systemic disease. One treatment regimen cannot address all uveitic patients. Treatments must be tailor-fit to address all patient concerns. So, that is it for my 2 lectures for this morning. May question ba? Wala. May question ba? So, I will upload a recording of this lecture sa Canvas. So you can access the lecture naman dun after I upload it. Okay? I think magkukuha tayo ng photo. So, turn on camera, sir. So everyone, please turn on your cameras.